To our next speaker, Dr. Ambika Shetty, who's a chief phaco and refractive surgeon from Gitanjali Eye and ENT Hospital, Trivandrum. Let's hear from Ambika. On to you.
A warm good evening to all of you. Is my screen visible?
Yes, visible. Yeah, start.
Okay. So thank you, Chitra ma'am, for the invite. It is really an honor to speak amidst all these experts in this webinar. Today, I will speak on a case of pseudo-exfoliation with dense cataract and a non-dilating pupil. So in the preoperative evaluation, I noticed that the patient had extensive pseudo-exfoliative material on the anterior capsule. As I was expecting zonular weakness in this case, I decided to use capsular hooks. So side ports and a clear corneal incision was made. When the capsule was punctured, I noticed that it was lax, but with frequent regrasping, I was able to complete the capsulorhexis gently. Once the capsulorhexis was completed, a gentle hydrodissection was done. Minimal rotation of the nucleus was done. 4 additional side ports were made and capsule hooks were placed. I also decided to make a 5th side port and put a 5th capsule hook over there. The nucleus was sculpted and debulked. The phaco tip was impaled into the core of the nucleus, and the nucleus was fragmented into 2 halves. It was a combination of a horizontal and a vertical chop to minimize stress on the zonules. The nucleus was further fragmented into smaller pieces. Once the fragmentation was complete, the pieces of the nucleus was emulsified in the pupillary plane and slightly away from the corneal endothelium. The residual cortex is removed by bimanual irrigation and aspiration. Tangential stripping of the cortex induces minimum stress to the zonules. I'm relieved to see the intact posterior capsule and bag after cortex aspiration and decide to proceed with the implantation of the intraocular lens. The lens is placed and the capsular hooks are removed. The viscoelastic is aspirated and the wound is hydrated. To summarize, proper preoperative evaluation is essential. Usage of appropriate intraoperative devices minimizes complication. and gentle surgical maneuvers reduces the stress on the zonules. Thank you.
Thank you, Ambika. The question to Dr. Sai. Dr. Sai, are you connected?
Yes, yes.
See, no, I think I'll take one question. Hello, Dr. Debashish. I'll ask him. Sorry. Yeah.
No problem. No problem.
Debashish, did you see this video now? So
yes,
he
it was a
had
wonderfully
so
done.
many
Satya.
capsular hooks. Don't you think we could have slipped in a CTR and played it safe, and that too, that kind of an obvious pseudo exfoliation? There has been some doubt over the stability that she put hooks. Wouldn't you have placed a CTR instead, because it will also take care of the fact that this is a progressive zonulopathy here?
Right.
Yeah.
One just as because this is a national forum, and what she used was fantastically done, but what she used was not iris hooks, it was the Macul capsular hooks.
She said
These were
capsular
used.
hooks only.
Okay.
Yeah.
But it was used mainly for the iris, or you just stabilize the capsule also?
Stabilize the capsule.
Capsule.
Okay. CTR would have made things simpler and would have, I mean,
She need
put
not have put
less-
so many side ports, She could have
Yes.
placed a CTR instead.
a
It's just
CTR somewhere between the in the middle of the phaco after removing one or two pieces, when
Yes.
there's enough space in the capsular bag, you could
Yeah.
have used a CTR. That would have made things simpler for you only, and also for the patient.
Yes,
Thank you. And cohesive viscoelastics below the endothelium was a must.
yes.
I hope you must have used it.
Yes,
Yeah.
that I've used.
Yeah.
Actually, the cataract was very dense. So that
Yes.
is why I didn't use the CTR.
Yeah. No,
No,
you
that
have-
is again, madam. Can I again? It's a personal preference of when to use CTR and how comfortable you are. Initially, long back, I used to put CTRs much earlier, during surgery. But I have later on realized that that is not actually required in many of these cases to put a CTR early itself. We can easily manage these kind of generalized zonular weakness with, if you need capsule support, or most of the times without capsule support also, if you have done a good hydrodissection. And pupils, this kind of pupils are actually, they don't usually come down. So close to 5 millimeter pupils, I don't put a pupil dilating devices also. But the crucial point is to have an adequate rhexis and not to chop off the rhexis or cause zonodialysis while you're chopping underneath this mid-dilated pupil, and have a good nucleus rotation while that all she did well. And small paracentesis are all okay. Putting iris or capsule hooks according to her comfort level, I think should be left to the person's surgeon's discretion, which will she be comfortable.
No. If it's a traumatic zonular weakness, I wouldn't have suggested a CTR, because it is a pseudo exfoliation and she felt some instability, imagined it. Not every hard cataract, she saw that pseudo exfoliative material, and that's what made her use capsule hooks. So why
But
not?
a CTR will not help in a progressive zonulopathy. CTR is not going to help in reducing it. It will only keep it stretched for some time and later help you in fixing the bag with the CTR. That is the only use of a CTR in a progressive zonulopathy.
Would you use a little larger rhexis, Dr. Sai, for these cases?
Yeah, as large as possible, and covering the areas of the pseudo exfoliation capsule.
Yeah.
So I think I would have probably done the same procedure as far as the zonule weakness is concerned, because I was not very sure I made out the amount of donesis due intraoperatively. As Minu said, if it is very minimal or not at all, I wouldn't have used any device. But if I need to use a device, I would definitely go in for a capsule hook. And at the end of surgery, then I will decide whether I should put in a CTR or not. So as we all know, earlier, every pseudo exfoliation we used to put CTR 5 years, 10 years back. But now many of them are coming back with the entire CTR bag complex, moving here and there, dislocating and things like that. So those are issues that has to be kept in mind.
Yeah.
But I would have done the same procedure if there was significant donesis. I also use the capsule hooks and not the intraoperative CTR.
Would you believe there is a role for anterior lens capsule polishing in this pseudo exfoliative cataract, Dr. Sugan?
No.
No.
Answering your question, no, I
No.
won't believe. And in fact, I don't, except in very young patients, I rarely ever do anterior capsular rim polishing because when she can remove the lens cells and they reduce the chances of PCO and other capsular fibrosis and other things. But coming back to the use of capsular hooks
No.
or
My thought for ALC was there is a tendency for phimosis to occur in these cases. The CTR actually keeps the bag stretched and less phimosis, a little larger excess again, little preventive to phimosis. So in that context, I wondered whether anybody considers
No.
capsule polishing. That's
I
all.
would rather have a large generous capsular excess than use a CTR to prevent phimosis. That is because a CTR in a progressive zonular loss is not achieving anything.
Yeah.
Unless you're using a Sioni ring, which is sutured, we are not achieving anything. If you're really going to prevent the bag from dropping down. But a question to Dr. Ambika is, what was the reason for you using a capsular hook? Because we didn't see any donesis at all.
It's a hard cataract. So
That's not a good enough indication.
No.
That is not
But
a
I
good.
think she
Let
felt
me,
it
because you
during
are
the
crowding. I would rather suggest that you use iris hooks and keep the pupil wide, make a generous capsular excess, and then you have more visibility. You see what things are happening. Because just to use, you could have actually damaged that capsular excess. When there's such a hard cataract, you put a capsular hook over there. The amount of movement that is happening over there, you could probably damage that capsular excess. So I'd rather recommend that you use iris hooks, keep the people widely dilated so you can have a generous capsular excess, and then go ahead and assess as it goes by. And yes, of course, you delay the using of the CTR. If you do see enough movement over there, we use hooks, and then we delay whether we want to use a CTR or a Sioni ring at a later stage during the surgery, depending upon what we finally assess as the zonular strength availability.
Thank you. I think we need
Madam, one small point is
speakers.
one small point is I make nowadays, if the zonules are really weak and when I aspirate the cortex, you see that the bag is coming and you see the zonules, I make 4 or 5 small cuts on the rhexis margin at the end of the procedure.
Excellent.
That again helps very much in reducing the phimosis. Phimosis is the point, is a problem.
Yes, 100%. Wonderful point. Good, we had these discussions. We go on to our next speaker. Thanks a lot, Ambika. Wonderful.